Hello everyone, my name is Anna Papke, and today I will be talking about gastroesophageal reflux disease, also known as GERD. This presentation is being completed for my NP 612 class, FAM Theo, Young and Middle Adulthood, with Professor Dr. Tamika Dowling at St. Joseph's College of Maine for the FNP Master's Program. Now, throughout this presentation, I will be reviewing the pathophysiology, some risk factors, clinical manifestations, as well as diagnostic workups, treatment options, and the role that the family nurse practitioner plays among managing patients with GERD. Overview of GERD. So GERD develops when repeated gastric contents are refluxing into the esophagus, producing symptoms that are interfering with patients' daily lives and can cause some pretty problematic complications. Now, oftentimes, occasional GERD can occur after a larger meal where that reflux is causing similar symptoms, but typically GERD is chronic and progressive. GERD is typically affecting nearly 20% of adults in the United States. And GERD is one of the most common GI disorders seen in primary care. This acid exposure that is occurring in the esophagus is causing some inflammation to the lining of the esophagus, and often when GERD is left untreated, it can lead to some strictures, some inflammation of the esophagus, Barrett's esophagus, and sometimes this can even lead to cancer of the esophagus. GERD can affect sleep, eating habits, daily activities, including functioning. So it is very important that early treatment is initiated and assessment is done in a thorough manner. Next thing that is important to talk about is defining GERD and the patho behind defining GERD. This diagram below is illustrating the pathophysiology of GERD. Typically, under a normal condition, the lower esophageal sphincter, or the LES, is acting as a little bit of a protective barrier that is preventing any of these stomach contents from going up into the esophagus, causing these symptoms. In GERD, however, this barrier, the lower esophageal sphincter, or LES, is either relaxed, it has become weakened, and it's not working properly. So oftentimes acid and bile then will reflux into the esophagus, and it produces that inflammation or that injury to the lining of the tissue of the esophagus. And when this happens over time repeatedly, it can really damage that integrity of that mucosal, and it can make the esophagus very weak, and it can make it more pertinent to injury. So the severity of GERD is really depending on, how frequent the reflux is occurring and how vulnerable that tissue has become and how weakened that tissue has become from that acid exposure. So some risk factors of GERD include aging, diabetes, hiatal hernia, increase in gastric acid secretion, a delayed gastric emptying, inflammation of the esophageal mucosa, like we discussed in the prior slide, but this is often due to NSAIDs, antibiotics, chemotherapy drugs, warfarin, opioids, L-andronate. And then in addition, things that are causing the LES tone to become weakened increases the risk for GERD as well. And some of these risk factors that weaken the LES tone are alcohol ingestion, certain medications, hormones, certain foods such as caffeine, chocolate, peppermint, fatty or spicy foods, citrus, nicotine, a BMI of greater than 25, or obesity and pregnancy. So with the aging risk factor, over time, the LES just weakens with age. So this is just in comparison can increase your risk for GERD with age alone. Diabetes, high blood sugars are related to damaging that vagus nerve and the gastroparesis. So that food moving through the gastrointestinal tract. And this occurs because there's some delayed gastric emptying. The hiatal hernia risk factor is due to the upper part of the stomach that is extending through the diaphragm into the chest cavity, and this can cause a disruption in the LES. If there's any sort of delayed gastric emptying, this is causing that back pressure of that LES and pushing those stomach contents into the esophagus. There's also certain medications that are causing damage to those tissues, and they can slow digestion, again, causing that LES to become more disrupted. Certain foods, such as peppermint, relaxes the LES. So often people, when they chew a lot of gum or have a lot of mints, when we're assessing dietary patterns for patients with GERD symptoms, this is definitely a common question that we want to ask, because sometimes just elimination of gum or mints that contain peppermint can really improve these symptoms. Those are, like I said, some of those big risk factors that we're looking for when assessing individuals with GERD. Pregnancy is definitely something that people can experience GERD throughout their pregnancy, again, due to that disruption of the lower esophageal sphincter. So the etiology of GERD has several compounding factors. Some of these include anatomy, a GI mobility issue, as well as gastric content variation, are some of these reasons why the etiology of GERD is multifactorial. Some modifiable risk factors include weight, diet, and mealtime, as well as the amount being eaten during these meal times. Alternative non-modifiable risk factors include family history, age, hiatal hernia, connective tissue disorder, and pregnancy. And there are a few different types of GERD, and it's not one size really fits all illness. There are different levels of GERD, and how they're treated kind of is based on the severity. There is NERD, EE, and Barrett's esophagus are all of varying types of those phenotypes that are relating to GERD specifically. So, particularly NERD stands for the non-erosive reflux disease, and EE is that erosive esophagitis, and then Barrett's esophagus. Again, these patients are often presenting differently and have to be managed in different ways as well. So some subjective data and some symptoms of GERD that we're going to see and want to make sure we're assessing for when a patient comes into the primary care office and we're suspecting GERD or they're having these GI complaints. So the big hallmark important symptom of GERD includes heartburn or regurgitation. Patients often are coming into the office and describing a burning sensation that typically is kind of between their sternum into their mouth. It's sour tasting. Symptoms commonly are worse after they're eating a large meal. They can experience worse symptoms when they're lying down, bending over, when they're drinking alcohol, or eating some of those trigger foods that we discussed before, like spicy foods, fried foods, peppermint. And during your history taking, it is important to ask about that timing of when they're feeling the heartburn, those aggravating factors, anything that makes it better or worse, and frequency, how often this is occurring, because this can help kind of guide our diagnosis as well. So some more things that we want to look for in terms of atypical esophageal symptoms as well as red flag symptoms. In addition to those common classic symptoms of GERD, people may present with some atypical symptoms as well. Sometimes we see people with a chronic cough. Some people have hoarseness, some asthma exacerbation, some difficulty swallowing or dysphagia. These are all audionophagia as well is something that we commonly see with those atypical symptoms. Some belching or bloating can be occurring as well. And those red flag symptoms that we need to look for because it can indicate like malignancy include progressive dysphagia, unintentional weight loss, GI bleeding, persistent vomiting, anemia, and painful swallowing, or again, the audionophagia. These findings definitely warrant a different treatment plan, typically prompt visualization of that upper tract or an endoscopy because we want to make sure there's not like a serious underlying pathology that is present. So objective data. So it's important to note that the physical findings on your exam are typically normal when assessing a patient with GERD. Unlike many other diseases, GERD rarely has a pretty benign exam, and you're not really seeing any like big findings on a GI exam that's gonna alert you that this patient has GERD. They often have pretty normal exams. Obesity is commonly present in patients, and this is due to that, like I said in prior slides, that increased intra-abdominal pressure that's happening, and that is worsening some reflux in patients. Again, it's like related to that increased amount of adipose tissue. The LES is experiencing more pressure, and then that pressure is weakening the LES, and regurgitation can happen. The chronic acid exposure from GERD may produce some dental enamel erosions or any laryngeal irritation. So sometimes you can see some dental changes on physical exam. Some patients also will be wheezing or have a chronic cough. And again, this is related to some like reflux-related bronchospasms that may be occurring. Ultimately, the history is much more of a valuable piece of information than the objective and physical findings for patients with diagnosis of GERD. There's no gold standard test for GERD, although stool can be positive for occult blood with a rectal exam. And essentially, this can just show that there's some irritated esophageal mucosa if there is blood on a positive occult. So this might give us some more information that they've been having some chronic GERD and now has resulted in significant irritation leading to a positive occult blood stool sample. Sometimes on exam you can see some epigastric tenderness. Again, this is kind of where that pain of theirs is typically after eating. So going off of objective data and physical findings of GERD, when there are some either red flag symptoms or some objective data that is giving us more information to maybe treat this patient with an endoscopy or an EGD, there are some things that we are looking for. This is not routinely performed for uncomplicated GERD, and it is not the first line diagnostic test in patients with expected GERD. It's reserved again for those patients that are having alarm symptoms, that have failure to improve after an initial therapy is initiated, which we'll talk about more in management of GERD, or those that are requiring Barrett's esophagus screening. 80% of patients that have a normal endoscopy are patients that often may have GERD. So it's not always standard that if you have a normal endoscopy that you're going to be negative for GERD. It can rule out those bad complications or malignancies, but it's not necessarily going to rule out having GERD. So when EE or erosive esophagitis is present, there is a severity grade that is used. And this is a Los Angeles classification guide, or the LA grading system that grades A through D. And this is kind of grading the extent of the GERD. So it can help diagnose the severity of the disease and guide treatment. So some differential diagnosis of GERD are listed in this diagram on the left. There are several conditions that can present similarly to GERD. These include some functional heartburn or those occasional episodes of acid reflux after a larger meal, peptic ulcer disease or PUD. We also have a non-erosive reflux disease, gastroparesis, hiatal hernia, as discussed earlier, gallbladder disease, acute coronary artery disease or ACS, and achalasia, and then one of those malignancies or esophageal cancer. It's very important to consider some differential diagnosis and make sure that some of the more severe differential diagnoses are ruled out. So like chest pain should never be automatically attributed to reflux disease. That's really important because if we have any sort of like cardiac symptoms, we want to make sure we're working them up before diagnosing with GERD. These patients with high cardiac risks are very important to rule out. Someone with gallbladder disease, we could do some further physical exams to see if they're having pain. Where is this pain located? Typically with acid reflux, like we said, it's kind of in the sternum area, so gallbladder disease would primarily be in that those right side quadrants when doing your abdominal assessment. So those are some big things to look for when looking for a differential diagnosis for GERD. So some laboratory findings and diagnostic workup when discussing GERD. So history taking is, again, one of the primary ways to diagnose GERD. Some of the history taking including coughing, regurgitation, a sour taste, dysphagia, hoarseness, and wheezing at night could indicate GERD. If GERD is suspected, then typically we try an 4 to 8 week trial of a proton pump inhibitor or PPI. This is typically taken 30 to 60 minutes prior to meals. And then we also typically are going on the 8-week end if you're not having immediate relief. So we'll continue taking that PPI for 8 weeks. Improvement would support a diagnosis of GERD. And if symptoms do persist despite this 8-week trial of a PPI, then either typically a GI or a gastrointestinal consult is ordered, and then typically a EGD or that upper endoscopy is ordered as well. There's also some additional labs that can be completed to rule out other medical conditions that may be occurring. If patients are complaining of chest pain, a troponin can be ordered as well as an ECG to make sure there's nothing cardiac occurring. Making sure we're ruling out those cardiac episodes versus those GERD symptoms. Oftentimes, sometimes celiac disease can have similar symptoms as GERD, so it could be important to get a celiac serology blood test to rule out any celiac disease. It's also important to maybe see a CBC with iron studies, what that looks like for results. Because if a patient has developed an ulcer that is related to GERD, it might show that they have low iron, and we want to make sure we're treating this appropriately as well. Making sure we're doing a CMP or a comprehensive metabolic panel that assesses for renal function and electrolyte imbalance is also important. And then also just checking for H. pylori as well, which is a bacteria that people can get. And this is treated a little bit different than GERD. A few different medications and some antibiotics are included to treat this bacteria. So some non-pharmacological managements of GERD is a big one is lifestyle change. So weight loss if your BMI is greater than 25. This is a really important part of GERD management. So we should really try those lifestyle modifications prior to any sort of medication management. Weight loss is really the most effective intervention for overweight patients. Additional recommendations include waiting 3 hours after meals to lie down, avoiding those larger meals, raising your head over bed at night when you're sleeping to prevent this reflux, quitting smoking if we have tobacco smokers, and eliminating those food triggers such as chocolate, peppermint, coffee, acid, spicy foods, and alcohol. So the plan of care continues for GERD with some pharmacologic management when deemed necessary. So the proton pump inhibitor remains that first line of treatment for GERD. Is the most effective agent for that acid suppression as well as healing for that erosive esophagitis. So typically omeprazole 20 milligrams daily, 30 to 60 minutes before breakfast is completed for about 4 to 8 weeks. And this is the common initial regimen that is performed. After these symptoms are improved, then therapy can be tapered down or eventually discontinued. Antacids can provide immediate relief when having some symptoms of GERD. Typically, antacids are taken when symptoms are occurring less than once a week, and calcium carbonate is a typical medication that is taken as an antacid. They, like I said, are typically used for more infrequent episodes. And then H2 receptor blockers are used as well for uncomplicated GERD and nighttime breakthrough symptoms, and common H2 receptor blockers are listed below, but the big one that is commonly known is famotidine. So here is the conclusion to this presentation. Here are some references that were used throughout it. Evidence-based resources were used throughout this presentation, including some current guidelines from the ACG, up to date, and the New England Journal of Medicine, and primary care textbooks were also used. I would like to just say thank you for coming and watching this presentation today on the overview of GERD, some assessment findings, treatment, and big things to look for when assessing for GERD. And I hope you enjoyed the presentation, and I hope you will get some benefit from it as future nurse practitioners moving forward throughout the program. Thanks very much.